So we are on time for our next session. This is on the IOLs for primary or secondary surgical correction of aphakia and the management of complications. I invite my co-speakers, Dr. Srini Edekalan, who requires no introduction, Sudeep Das, Shane from Chaitanya Tiruvalla. My colleague from Chaitanya Cochin Palarivattam is Sachin. And I'll move on to my first talk, which is the classic scleral fixated techniques. The principles is that the suture should penetrate only the sulcus and not the iris or adjacent ciliary body. The loops of the IOL optic must be directed primarily into the sulcus. The IOL chosen should be designed so that it suits the anatomic needs of the procedure. So the 90 proline, if we want to actually visualize, we can use endoscopes, and you should have an IOL with eyelets. So this is a video made by a former fellow of mine, which uses the model using various disposable in-house gadgets, and here she is demonstrating how to create a flap, thread on one side, and get the idea of railroading using a hook, using a straw on the other side and a knitting needle on one side. And this is a very essential skill when we are doing the regular sutured SFIOLs. Knowing where the sutures have to go from and where it has to be exteriorized, how to cut it, and using a model IOL which is created with fibrin glue, she is able to then proceed and place it in the model eye, knot it under the flaps, and this gives a very good idea of how the procedure has to be done. So we'll just go quickly over a video of the actual scleral 4-point fixation technique. Here the superior incision is made, cauterized. 4 millimeters behind the limbus is where I initiate the scleral pocket. I don't make flaps, and using a crescent blade, I tunnel partial thickness sclera into almost a millimeter behind the limbus. I am making the superior scleral incisions. Inferior side port is used for the anterior chamber maintainer, and a good adequate vitrectomy is required at this stage. Incision is enlarged with an adequate internal corneal lip, and the straight 90 proline needle is advanced and railroaded and taken out through the 26 gauge needle on the other side. So we have to mark what Dr. Minu had shown in the previous thing. Mark and make sure it is 180 degrees opposite each other, otherwise there will be decentration. And practice, just confirm that this railroading will happen outside the microscope before entering into the eye. The suture is cut exactly in the middle, and each end is threaded through the eyelet and then knotted. Because this is 90 proline, a single knot is not adequate. Typically, I take 3 throws of 4 knots each, and then both sides, once it is fixed like this to prevent slippage, I will insert the lens, the leading haptic of the lens, making sure not to entangle the suture at any point. The leading haptic goes in while maintaining some traction on the suture so that the suture is not entangled. Withdraw the suture on the left side also, tighten, center it, and as we tie the knots, again this will be 4 throws, 3 knots, so that is totally 12, and the knot slips and gets buried into the scleral pocket. Then the rest of the procedure is simple, just close the conjunctiva and cover it and finish it off. This is variation where it is done under a scleral pocket, and this is the sutureless variation which has been shown. Hoffman's pockets can be used. Dr. Sudeep's favorite technique. Basically, you are creating a groove from the corneal side into the sclera, partial thickness, then taking a loop through the eyelet of the SF IOL, and this one, so the first one passed through is transconjunctival, the second pass is railroaded through the 26 gauge needle on the other side. Both sides are withdrawn. The trailing haptic is introduced into the posterior segment and then withdrawn. Once it is well centered, the knots are tied and the knots automatically get buried. Sutureless techniques by Shariat was the pockets. Amar Agarwal modified it with the scleral flap and fibrin groove. The Shin Yamane was the one that came with the easier modification to exteriorize the haptics and using low temperature cautery to make the flanges. A variation of that is the Canabrava technique, which uses the flange for any type of lens, specifically the Bausch & Lomb Acryos AO. Late complications include endophthalmitis due to suture exposure, suture breakage, late exophyal dislocation as what has been the primary cause for making this a less popular technique. IOL haptic may break from the optic, choroidal or vitreous hemorrhage, retinal detachment, hypertony and lens tilt. Thank you for your attention. I'll now invite Dr. Sudeep to talk about the CMT Flex lens, which is a more recent new innovation.
Thank you, Matthew. So this is the CMT Flex by Nivian Madhivanan, but I do it in a slightly different way. So this is the hydrophilic material. It's the only lens which has actually been designed as use an SFIOL. And it's a sort of a 14 millimeter lens, and the optic is 12 millimeters. And it's got these small T-haptics, T-shaped haptics which come out through the sclera. So he described it the traditional way with two partial thickness limbal-based scleral flaps, and the haptics come out through that, the rest under the flap on the sclera. While what I do is through a Hoffman's pocket. So this was a badly subluxated brown cataract. You'll make out when I remove it. So I made these partial thickness cuts on the cornea, as you can see, and then I make Hoffman pockets. The reason I start in the clear cornea is I know the initial dissection, what depth it is at. If I start at the sclera, I really don't know what the depth is. Initially, I would suggest what I did. I used to use these preset 300 micron blades. So you hold it vertically, make a cut, it's exactly 300 microns. You go at the depth, but I've done like hundreds and hundreds of these, so I don't use that anymore. That cut is, of course, for the subtenons block. So these are the Hoffman's pockets, which I've dissected on the two sides. And then the SICS tunnel has been made. It's a large one. And then when I touch the lens, you look at that. So now you see how badly subluxated or dislocated it is. So I just rotate it out into the anterior chamber and then pull it out. And then this is not the way you do the vitrectomy. Actually, vitrectomy has already been done through the side ports. This is only the last part. And then I make a 21 or 22 gauge entry through the Hoffman's pockets on both sides, about 1.5 millimeters from the limbus. And this is the lens, as I showed earlier. And this is the very first one I did in this method. So I'm using VR forceps. And this was anyway a large incision. So just use a handshake technique, hold the T of the CMT flex IOL and pull it out onto the surface of the eye. So it comes out completely to the surface at this point through the two layers of the Hoffman's pockets. And then support the IOL so that you see the other T. If you see the next surgery I show, actually use two forceps through the side port and again pull this out. So you have this haptic which is traversing both the layers of the Hoffman's pocket. So you go through the mouth of the Hoffman's pocket and just draw the T out from the surface into the Hoffman's pocket. So it rests between the two layers of the Hoffman's pockets, and that's the end of the surgery. So the the wounds are hydrated, and that's the end of it. And this was one where it was a secondary IOL, and again I make two Hoffman's pockets. So this you can do, like I said, instead of with the side port blade, you can make a opening with a 300 micron blade, guarded blade, and that is for the AC maintainer. Again, dissect the Hoffman's pockets. There is a bit of a learning curve here. You have to make sure you are going at the right plane all the time. So that will be around 2.5, 3 millimeters. I'll enter about 1.5 millimeters from the limbus. But always start at the clear cornea so you know what depth you are going at. So this is one I'm doing with injector. So it's a 2.8 millimeter incision. So I insert a Sinski's hook here before I make the opening so that I know that I'm going through an area which I've already dissected. You don't want to make an entry where you haven't dissected. You don't know where it is once you've dissected the Hoffman's pockets. Same thing I do on the other side. So actually feel the Sinski when I enter. So once that is done, this is the CMT Flex IOL. It's got an angulation, so make sure that it's angulated backwards when you load it. This is a normal Lacrifold injector, and it doesn't get caught because the haptics are straight. It doesn't have a loop haptic, it's just a small T, so it doesn't ever get caught in the flanges. So once that is done, I go in with these. He actually has, now I have, these are basically 23G Rexis forceps. Now I have his forceps, which he calls the Pranit forceps. So hold the T, but don't pull it out now, till the IOL has completely come out of the injector. So the trailing haptic is now in the wound. At this point, I will remove the T out onto the surface of the eye. Then I go in with these other forceps, support the IOL, and go through the other side. Again, hold the T. And gently pull it out onto the surface. Then again, what I have to do is go in with a Sinski or any other instrument, just hold the neck of the T and draw the T part, the part which is right angle to the neck, into the Hoffman pockets. Do it very gently so it doesn't break. And don't make this with a 23 because you can break the neck. So ideally with 21, you can do it gently with a 22, but preferably with a 21. So once that is done, you just hydrate the wounds and your surgery is over. So this is the simplest form I found to do a SF IOL now, and mostly I do this after having gone through many, many other techniques. So this material is of course extremely biofriendly. We used it for a long time. It doesn't center, there's no tilt. There's one, the first case I did, I found that the IOL was tilted because I was so excited that I did it. I didn't realize that the haptic was sort of not straight. So I just went in to the OT, just sort of touched the haptic and the whole IOL straightened out. There's no dissection of the conjunctiva because I'm making Hoffman pockets. And I've never seen a leak. I've sort of put trypan blue, I put also the thing to see whether it leaks or doesn't. Because the T basically plugs the opening, the internal opening. The T of the haptic avoids the need for any tucking in or cauterization. It's meant to be used as an SF IOL. It's a single piece design, so there's no possibility of haptic disinserting from the optic, as I've had earlier. And the T sort of sits securely within the Hoffman pocket. So once it reaches intraocular pressure, it's sort of tightly bound down within the Hoffman pocket. There's no need for glues or sutures. Thank you.
So, what is the size of the sclerotomy preferably for beginners?
21.
And 21.
21 it will go in easily. You can do it with the first one actually I did because I didn't have forceps for that. I didn't know whether I should be using my capsular access forceps. So I borrowed an instrument from what the VR surgeon does. And she actually is using a 19 gauge.
Okay.
So I had to use a 20 gauge and sort of stuff this in. Next one I use my 23G capsular access forceps. So 21. Now I have the Pranit forceps which are much flatter. But then you don't want the haptics to break. So ideally, I would say 21.
And while we are waiting for Dr. Srini to come for his talk on iris claw, George Maneth was not able to make it due to personal reasons. I thank Dr. Shane for stepping in at the last moment. All of us are anterior segment surgeons that are doing this procedure. We do anterior vitrectomy from past limbal approach. What would you consider as adequate? Srini runs in, so we'll take that question after Srini's presentation. Thank you very much, Srini.
Thank you, Matthew, for including me in your session. This is my favorite lens, my choice for correction of aphakia. So this is one that I started with, designed by Dr. J.K. Reddy, and it's an all PMMA lens. It has two haptics here, and that is a claw. There is a split there. That is into which the iris is trapped for enclavation. Okay, the surgery is done through a scleral tunnel, PMMA lens, obviously. So the tunnel is made. Two side ports are made 90 degrees away from it. The second entry is made diagonally opposite. Constricted with the pilocarpine. Ideally, if it constricts this much, it need not be constricted this much, but I'll come to that later. So entry is completed. The IOL is inserted into the anterior chamber, initially kept on the anterior surface of the iris, and it is rotated in such a way that the haptics are aligned to the side ports that we have made. Okay, so one side port here, one side port there. Now you catch the optic with the lens holding forceps, tilt the haptic on that side under the iris through the pupil, then you lift it up. So, there is a tenting that happens there, and using a blunt rod introduced through the side port on that side, just push the iris down onto the haptic claw. Just go down vertically. So this maneuver traps a bit of iris onto the haptic claw. So the same thing is repeated on the other side. Haptic goes under the iris, tilted up to cause the tenting. The blunt rod goes in, pushes down, and this fixates the iris claw lens onto the posterior surface of the iris on that side also. So this is it. It's a pretty simple surgery, and it gives a very stable intraocular lens. So that's it. You have a round pupil. Always you don't get a round pupil in iris claw, but that is okay. So this is the end of the surgery, and you have managed the aphakia there. So this was the lens that was there before. It is a bigger lens with a larger diameter. So I don't take off whatever capsule remnants that are there, because it prevents that pseudophacodonosis that you see with iris claw lens. Again, the haptic goes down. See, you can see here, the pupil is not round, it's a cat eye. So that is how I told JK sir, so reduce the overall diameter of the lens. And this was the lens with which I initially started. It's an AC iris claw lens. That's a very small one. With this iris claw lens, I never had a non-round pupil. The problem is it's just a 4.5 millimeter optic, and you can have the edge coming in the pupillary area, and also, so I would prefer to do iris claw lens in a secondary second step if it is something that is unplanned. Okay, I'll come to that later. This is another situation. It's a pseudo exfoliation. IOL is in the back. CTR is there, but it is progressively subluxating. So what to do? I don't prefer fixing it and all. Just take out everything. The bag, the CTR, the IOL, everything comes out. So once everything comes out, you obviously have to do a vitrectomy and then do the same procedure. The IOL goes in, rotated so that it's aligned to the side ports, goes down under the iris, goes up with the rod, you push it down. What I use for a rod is I break the tip of the Sinskey hook. That gives a pretty good one there. And what to hold with, I use a normal lens holding forceps. Different people have different, there are special holding forceps for this thing, but I find this more comfortable. The tilting and all occurs much more easily. See, what if one of the haptics get disenclavated? So this was a referred case. So you can see that it is disenclavated at one point. But once it is enclavated, that the enclavation in the other point is there, you can actually manipulate on the optic and bring the haptic back into the AC. And if the haptic is not damaged, then you can re-enclavate it. See, the issue is not that this is not supportive. Iris tissue, those collagens there is as strong as the sclera. So it is because the initial enclavation is not proper. Not enough iris tissue has been enclavated. See, I had 2 cases in my initial period. You don't really know how much to enclavate, and you're scared. You might break the haptic and all. It doesn't happen. So if you enclavate enough of the iris tissue onto the haptic claw, it is stable. It is rock solid there. The only thing that you see is on slit lamp, you might see the tremulousness, pseudophacodonus is there. So this hasn't re-enclavated. The pupil is irregular because it's a compromised situation. So this has been re-enclavated, and this small area, if it really causes some glare and all, you can switch the iris and handle it. So this is iris claw lens. This has been there for a long time, but the design and everything has evolved over the years. See, the lenses that I've shown is that Dr. JK designed. It doesn't have an angulation. So I was telling JK sir, okay, we should have an angulation and all. He said, Srini, they might put it ulta, then it will cause a lot of trouble. But Appasamy IOLs has an angulation. And with non-angulated ones, you have to do a PI. Otherwise, in maybe in 100 cases, one case, you might get a pupillary block, a glaucoma. But with the angulated ones, I'm not doing PI these days. And the way in which you enclavate here, you can see it goes down directly. With enclavation, I go a little bit on the slanting motion I do. And you can see it's as I said, I don't remove whatever capsular remnants are there, because I've seen that it doesn't, it prevents that pseudophacodonus is there. Thank you.
Any difference in the nature of doing the paracentesis, like a regular side port, or is it a little more posterior
It's a regular side port.
Okay.
I don't really go that posterior. It's a posterior limbal side port.
Thank you very much, Srini, taking time off from your busy schedule. Going back to the anterior segment versus posterior segment question, Shane, you're up. Where would you consider an adequate anterior vitrectomy in these kind of situations? How would you approach SFIOL, and what would you consider adequate anterior vitrectomy for an anterior segment surgeon?
So there are two parts of the answer. I guess let me put it as two questions. Is anterior vitrectomy enough for a secondary IOL implantation? Number one. If at all one was to do an anterior vitrectomy, how good an anterior vitrectomy can you do? So I'll try to answer the second question one. I think that is what Dr. Matthew asked. I personally am a vitreoretinal surgeon, so obviously my answer is going to be inclining towards the vitrectomy, but I have my own reasons. But now let me answer the first question. How to do a good anterior vitrectomy? To know that, you should know the anatomy of vitreous and what is happening to a vitreous when there is a PCRN and a vitreous prolapse. So it's like a water-filled body with collagen tubules, and the collagen tubules is sort of floating inside this water body. And the moment it jumps out into the anterior chamber, what happens is automatically there is a traction. And the tractional forces are very minimal, obviously. But when you start manipulating inside, obviously these tractional forces hit hard at the area where the vitreous is very strong, and that is the area of pars plana and the periphery of the retina. And that is why we do a good anterior vitrectomy. So it is imperative that those area has to be freed of vitreous to put a secondary IOL so that the traction on these area is less. To do that, of course, you stain the vitreous in the anterior chamber with triamcinolone. And always remember, when you use in cutting, we are scared to increase the cut rate, but actually increasing the cut rate causes lesser traction on the vitreous. So we use 5,000 cutting rate cutters. Anterior segment cutters are not that high in cut rate, but if there is a combined posterior segment surgeon working along with you, you can always use his cutter and use it for anterior vitrectomy. That is much safer. The second point I would like to emphasize is there should be adequate suction. Don't be scared thinking that if I increase the suction, it's going to cause more traction. It is not so. When the cutting is high and the suction is more, it works very efficiently. Only when the cutting is low and you have more suction is when you actually cause undue problems. So that is the one message I want to put across. And the second one is, we are always hesitant to do enough vitrectomy. The moment you clear the pupillar area, you're happy. Yes, I'm done there. But actually, the problem lies just beyond that. There is no harm in introducing your cutter through the PCRN into the vitreous cavity centrally. I use the word centrally. So keep the vitreous probe down and keep cutting. Nothing is going to happen. It is going to eat the vitreous all around. It is not going to cause any retinal incarceration of anything of that sort. If there is adequate hydration and eyeball is steady without a collapse, you do an excellent vitrectomy out of it. Now the second part of the question is, yeah, so when the cut rate is very high and the suction is very low, there is only chewing of vitreous. There is no sucking of vitreous inside. So you want chewing of the vitreous as well as sucking it or aspirating it into the cutter. So that's why I said higher cut rate. And you keep the vacuum at even 300, 400. The simple thing is use cutters now used by VR surgeons. You can definitely do an anterior vitrectomy with it, and you can do it much more efficiently. And the second point I said is insert into the center of the vitreous cavity. Let it go beyond the posterior capsule. And nothing is going to happen. It's rather a safer way of eliminating vitreous. The second part of the question is it enough to do an anterior vitrectomy while doing a secondary IOL? Well, if I answer this, 3 of them are going to come and hit me, but then still I have to answer this for the benefit. Yeah, I can answer. I do iris claw, do SFIOL, and I do CMT flex as well. So to answer that question, so what happens, I would put it as 3 scenarios. One, you have a well-dilated pupil, you're doing phaco, you had a PC rent, an experienced phaco surgeon is doing vitrectomy and putting anterior vitrectomy and placing a secondary intraocular lens. Let's keep that towards the last. And let us put 2 other scenarios where there was a complication and a week later it comes to you, or 1 month later it comes to you for secondary IOL implantation. You will do a good anterior vitrectomy, but the vitreous is very elastic, and what happens is over time the vitreous gets adhered to the surface of the iris. So you will do a good anterior vitrectomy, you will clear the vitreous from the anterior chamber, but you will not clear it from the surface of the iris. And many a times this creates a serious problem. Now how do we eliminate that? Only by doing a posterior vitrectomy towards the plasmana area that you can actually relieve all the traction technically. So here is that situation where the IOL comes in secondarily, maybe a week or 10 days later. I definitely feel a posterior vitrectomy has to be done while placing an secondary intraocular lens implant, be it scleral fixated IOL or an iris claw IOL, because of this particular reason. Another reason which I want to say is many of them will have nucleus drop and there are cortical remnants in and around. You would have taken the chunk of the nucleus out. From your point of view, you look as though the vitreous cavity is clear, but there will be chunks of vitreous in the periphery. And this may cause undue reaction in the postoperative period. So yes, IOL looks good, everything is fine. A week later, 2 weeks later, 1 month later, there is steroid cover, things are all good. But what happens 6 months later? We are not thinking about a late onset cystoid macular edema, and we are not thinking about a late onset retinal detachment. So I'm a surgeon who does that, and I've seen that many a times the secondary IOL related retinal detachment will not have big tears. You can directly see. No, these are small micro dialysis near the aura, or there could be tiny one tear at the near to the aura, which is actually causing a total retinal detachment. And this can be easily missed the next day postoperatively, because many of the pupil won't dilate. Even a retina surgeon may not be able to find out this break. So considering all this, to do a complete vitrectomy before placing the intraocular lens implantation divides us from this, and if at all there is an intraoperative tiny tear, a retina surgeon can pick it up, because we will be doing a depressed evaluation of the ora serrata before placing the secondary intraocular lens. So we do a 360-degree barrage actually to prevent many of these complications later on. But having said that, is there a situation where actually an anterior segment surgeon can do an anterior vitrectomy and a scleral fixated IOL or a secondary IOL? Yes, a well-dilated pupil, and immediately there was a nucleus PC disturbance, and then you do a good vitrectomy, you can almost view the entire retina. Maybe is a good enough idea to do an anterior vitrectomy and put a secondary IOL. And last but not the least, I would always think whatever is good in your hands is the best technique. So I wouldn't advise what technique to be used, but if it's going to give you good results long term, I think that is the good technique. Thank you.
Thank you very much, Shane. I invite Sachin now to talk about some of the complications that we have seen referred to us from outside and how we went about managing it.
Yeah, good evening. Thanks, Dr. Matthew, for including me in the IC. So, I mean, you know, in this IC and the last one, actually, we were discussing about the IOLs for the primary and secondary correction of aphakia. So, my job is to deal with that second leg of that management of complications. So, why this talk came about is because of these 3 scenarios we both came across in our OPD in the last 2-3 years, actually. 3 of the cases are more or less similar. 68-year-old male patient, gradual blurring of vision in left eye. Cataract surgery done 12 months prior. 76-year-old female, blurring of vision, cataract surgery done 4 months prior. And the last one, 2 years prior. So, I mean, later once you see the cases, the presentation, you will know the different layers of problems we encountered. Now, the first patient, the 68-year-old male patient, I mean, gradual blurring of vision, diabetic for 10 years, cataract surgery done in both eyes, elsewhere 9 months prior. The vision at the presentation was 660 with pinhole at 624. He had a corneal edema, and you can see that there is a localized corneal edema. It's temporarily. In the ACIOL, the trailing haptic was brushing on that cornea. And there was a PAS at that area. I mean, at this stage, it looks like an ACIOL which is causing early decompensation. So the natural instinct will be like, first we treated it with topical steroids, hyperosmotic agents, AGM, and then we'll plan for the ACIOL explantation. And that is when, when you explant the IOL, that is when we note these different layers I was talking about. The trailing aptic was actually found to be sutured to the wound lip. That is very rare. I mean, that was, and the posterior capsule was found intact, except for an nasal small PCR. So, I mean, the primary surgeon could have actually put the IOL on the PC itself, but there was an ACIOL, and the haptic, the trailing aptic was actually sutured the wound. Now, that is when this is the first time we have encountered, so the management also was a little, debatable. Secondary IOL was implanted again because the PC was present, so the IOL was kept on the sulcus. Now, the cornea was not improving, the cornea was again, that is when we planned on to the endothelial keratoplasty, which we did. That is when, the patient's, the suffering or the trauma has not ended there also. Again, the patient presented with, this has all happened in a span of around 6 months. So, my VR colleague Shane here did they found that there was an inferior RD. He did the retinal reattachment surgery, and then he did a silicone oil removal, and the patient is now with the 636 and the last time when he was reviewed. So that's the first patient. Second patient, this time we were a little more prepared actually, because this time when the patient came, we knew that something is wrong there. So 76-year-old patient, gradual blurring of vision, again the same history. It was done elsewhere. This was done at the same center like last time. So we were actually, pretty sure what this haptic was, where it was. Here we can actually see the haptic extrusion within, actually the tennolinol suture was there lying on the conjunctiva actually. So this is what we did actually. This is the first procedure we did. So when we push that, you can see that when you pull it, it's actually tight there. So actually the tenonylon is actually going through that and taking that haptic piece also. So I actually created something like a scleral pocket there, so that this haptic can be just tucked in. Anyway, that was my idea initially, at least. So the haptic was, we didn't want to take out the ACL because the central cornea was still relatively clear. So we put that sutures and then put a fibrin glue and we put a glue on top of that, and the conjunctiva was covering that. So that, I thought that is the end of the thing. The haptic was not extruded, and the patient was happy. The patient was, the symptoms was relieved. But unfortunately, the patient again came back with the haptic extrusion again. Now the cornea was cleared, and you can actually see the epinuclear bit also now. So now it's getting more and more layers. That's what I'm saying. Initially when we saw all these things was not seen. So now ACL explantation was done with an anterior vitrectomy with epinuclear bit removal, which is done under RA. Now the problem is now the patient, again the cornea, the superiorly there was an epithelial ingrowth and all by this time now. We have to do a full thickness penetrating keratoplasty with the secondary IOL later. But the patient actually is a little disappointed at this point of time. Now the third patient, by that time, again, the same picture, haptic extrusion, cataract surgery done elsewhere, then HM. But this time, I didn't go for all these ACL explantation, and this directly we did a PK. But the problem is when you do a penetrating keratoplasty and try to take out the IOL is almost plastered to the iris actually. So we have to cut it, and some of the parts we can all remove it also. Since it is PMMA, I just left it there. But unfortunately, by that time, his disc was pale, and then, the cornea is still clear with a good specular cell count, but I don't think it's a good patient or a good candidate for a secondary IOL at this stage. So why this part was, these three cases included is, especially in the first case, imagine the kind of interventions we had to do. This was almost like 5 interventions because of that first, the surgery. And the second one twice, and the third we did once. So the conclusion, as a conclusion of why this talk was here is because surgical correction of aphakia we discussed, and we heard about a lot of methods and different IOLs and all this stuff. But when to do it? Is it the primary, when you have the complication at that time, or as a secondary procedure by you or someone who is like a little more trained in that? That you have to decide at this point, because the patient is the one who is suffering. I mean, you can actually do it in the first sitting itself. So Shane was discussing about that. If you have a large pupil in your anterior segment, you're confident in doing it, do it. But if you do it, an ACIOL, like Minu said in the last talk, ACIOL, according to Dr. Chang, you can still do it if you're doing a good ACIOL. But do it and do it properly, and not like that, the haptic, what we saw. That is why this talk was planned and done. Thanks, Matthew. Yeah, thanks.
Thank you very much. Do we have any questions from the audience? Yeah, Dr. Sandhya.
One small question, sir. When the pupil is widely dilated, that is limbus to limbus, when we are doing anterior vitrectomy, is it better to slightly constrict the pupil and do it, or do it in that position itself? Because when the irrigation is on, we will be hydrating more and more vitreous. So I just wanted to ask this. So what I have seen is
the wider the pupil, the better it is. Okay, let the vitreous come in. We want to take away all the vitreous, how much ever it's going to come outside. So more vitreous is coming, it is good, because spontaneously we are cutting and removing it. All the more better. So the pupil has to be really wide. And I say that because there will be abnormalities near towards the root of, to the aura. So that can be tackled better when the pupil is wide.
Thank you.
I think there is a difference in how you would approach anterior vitrectomy if you are planning a secondary IOL like this, versus if you are having an intact rhexis or just a small central rent and you want to clear the vitreous from that area. So in the situation of a small rent, you want to just clear, you don't want to keep pulling more vitreous forward. But here, like almost every situation, the IOL is going to mid-vitreous or so. So you want to make sure that you are taking out a good amount of the vitreous from there. Second, I would re-emphasize the need for having a good anterior chamber maintainer, because otherwise the globe will keep collapsing, choroidals, all those things, or you are putting visco all the time, and that visco is going to posterior segment and never going to come out. So I would say well dilated, as best dilated as possible. Not dilated, probably leave it, send it to Shane.
I just have a comment to make. Interestingly, I operated a fisherwoman and put her with iris clip IOL, and she said, "Doctor, everything is fine. I can see very well. But whenever I look in my house, I can see that there is live fish inside." So the pseudophacodonosis she was actually perceiving as mean vetinadovale. This is exactly what she said. So this could be a symptom that the patient with the iris clip IOL can perceive.
But one thing, whatever I do, I will send the patient the next day and the week after and a month later and forever probably to my VR surgeon to check the retina. That is very, very important. Dilated retina, indentation, whatever she wants to do.
What would be your approach? Like you're doing a pseudo-exfoliation case and there is an unexpected bag coming out. What would be the preferred method of handling? Pseudo-exfoliation, unexpectedly the bag comes off.
I actually won't do a secondary IOL, primary, whatever I won't do. I will remove the bag, do a vitrectomy and leave it at that. I have no problems leaving people aphakic on the day of the primary surgery. Then evaluate it, talk to the patient, tell them honestly that this is what happened. And then plan for a secondary IOL much later. I will never do it on the first sitting.
I think we have to take out from our mind saying that aphakia is not, it is not a sin. So I think that is why we immediately do all measures trying to cover it up, put a lens somehow, keep the patient out so that we are happy with. Actually, we are going to land up in more problems. But be bold enough to say that yes, the cataract was little, untoward and, we could not place a lens, but sure and certain we are going to, because if you look at the literature, the success rate following a secondary IOL implantation is almost 97%. So it is really good.
And the problem is actually the panic. I don't know how many ACIOLs I have removed and put in the sulcus 3-piece lens. You won't believe how many of them I have done in my lifetime. So it's just the surgeon panicked and then put an ACIOL, and without probably having done a proper vitrectomy also, because there usually be vitreous in the anterior chamber. So That won't happen if you don't panic. Leave the patient aphakic. You might even be able to put a 3-piece IOL in the sulcus later.
Dr. Sandhya?
So in pseudoexfoliation, if you place the IOL inside the bag with the CTR, the chance of pseudophacodonosis is very high. So if you do place the haptic in the sulcus and do an optic capture, then there won't be any pseudophacodonosis.
That is the best option.
That's the best option.
That is the best option. Put a CTR in the bag if necessary. Put a 3-piece IOL, but it has to be a 3-piece IOL.
Yeah, it's 3-piece
in the
IOL.
sulcus. And if possible, do an optic capture.
Because with the weight of the IOL plus the CTR, each time the patient moves, it keeps on dislocating more and more.
But if the rhexis is little on the larger side, we will not be able to do an optic capture.
Yeah, that is actually another way of fixing lens in pseudoexfoliation, because if the diameter of the rhexis is more, the sphincter action for phimosis will be less. So there won't be much of capsule contraction if you put like that, if you make a larger rhexis, just overlapping the optic.
So David Chang does. He finishes the surgery, puts the IOL, and then he does a much, much larger axis again.
Sudeep, 1 minute. You said about the ACIL removal, you had to remove a lot of ACIL. At what stage, I mean, I find this sometimes, in ABK, when you do a keratoplasty, removing the ACIL is going to cause more trauma, So at what stage you decide whether to remove it or just keep it?
If I see the iris is still looking all right, then I'll think of removing it.
Because you said about the vitreous coming out and the lens is still
Yeah, so a lot of these won't be very late post-op, but done elsewhere. But very late ACIOLs where the iris looks bad, I won't even attempt to do anything, because I'm transferring the blame from the primary surgeon to myself.
Okay, that is one dilemma I always have. You remove the ACIL.
No.
Yeah.
There you can make out that it's adherent. I won't even attempt to do anything. Present day medical legal situation, I won't attempt to do anything.
Now, the problem is the patient came to you with a bullous keratopathy because of the ACIL.
Then it's different. Then I'll send it to my cornea person.
No, that is...
How many of us have seen posterior chamber lenses in the anterior? Okay. So I think the take-home message is there are fantastic methods of now doing correction of aphakia. There is no need to panic and be forced to place a lens somehow, somewhere. Okay. So in the first case that Sachin was showing, there was actually 360 degrees capsular margin, and after the lens was explanted, we were able to place a MA60 in the sulcus. Eventually the prior damage was so much that DMEC was required, vitrectomy was required and all that. And these techniques of having suture through the eyelet onto the iris, leaving a trailing haptic stuck into the wound and suturing it, all that is not necessary. Just even if you don't have the lens on with you at the OT at that point of time, because you don't have a library, it's very easy to call the patient back and put the most appropriate lens for that clinical situation 48 hours later, a week later, or a month later. Patient will thank you lifelong, rather than have this kind of 5 to 7 recurrent episodes of surgery required. Any comments?
No, as a vitreoretinal surgeons, we do see a lot of patients where most of the times it is mismanaged and a panic, as already spoken by the other speakers. My only thing is, as an anterior segment surgeon, is do always have a vitrectomy machine. If you can invest so much of money into the phaco machines, buying so costly, please do buy a simple vitrectomy machine. Keep an ETO sterilized vitreous cutter which is functional whenever you have any option, and just do a fair amount of good anterior vitrectomy, and depending upon your comfort zone with which type of a lens you would like to rehabilitate, you do it. If it is not so, you can leave it to one of the vitreoretinal surgeons who can do fantastic job in this. But the basic thing is no vitreous in anterior chamber should be the dictum.
Any questions, further questions from the audience? We have got a couple of minutes more. Otherwise,
CMT flex IOLs. Actually, I use ILM peeling forceps. After a couple of ILM peelings in macula hole, the forceps get a little blunt. So I use those forceps in enclavating those CMT flex IOLs. And in my initial days, I had few of the where the T junction, it got dislodged, or rather got ruptured while I was pulling it out. And that is one of the problems which I faced during my initial days. But then now I sort of circumvented by pulling it in a slow and steady manner rather than using a jerky movement to pull it out of the scleral incision which you have made.
My experience was that I was tending to hold it very tight because I was afraid to lose the grip. So it was actually the forceps that was snipping the acrylic material, hydrophilic acrylic material.
Very soft
Yeah.
material.
So you just need to use a reasonable amount of force just to make sure that you're not getting slipping off from the forceps. And with the 21 gauge sclerostomy, I am able to take it out and do the Hoffman's technique.
I use a 23 gauge sclerotomy, but probably I'll try a 21 gauge out
It's much
after
easier.
seeing yours. Yeah. Then, yeah, absolutely. I don't do a Hoffman's, I do a routine scleral pocket, yeah.
I think, thank you for the audience, for your patience. Thank you very much. I hope we have had a very fruitful discussion and some food for thought for future practice. I'd like to invite my co-instructors, please, for a photograph. Prashant, why don't you join us?